We do have 3 presenters today. Before we get into the presentations themselves, I want to go over some ground rules just so that everyone is aware. We will be recording the sessions. Anyone who is not a presenter will be muted for the duration of the presentations. And then lastly, we have disabled the Zoom chat function. And so I would ask Mary Margaret if you can share your screen really quickly. We ask that you be posting your questions for our presenters into the chat tab under this session for the presenters. Each presenter has 10 minutes to present and then 5 minutes of Q&A. The first presenter that we have today is Bram Riems from Action Against Hunger. Bram, if you would like to share your screen and get started, that'd be great.
Hi everyone, can you hear me? Is the sound okay, Timothy? I think it is. So I'm with Action Against Hunger. I'll present on a sanitation marketing approach that we did in Cambodia in rural areas, and more particularly on how we evaluated this approach through a case control study. This was done together with Anchor Research, which is a consultancy bureau based in Cambodia. So our setting, first couple of slides to explain what we did, was in rural Cambodia, so the northern province of Preah Vihear, which is close to the border of Thailand, and which had high rates of undernutrition, both acute as well as stunting, caused by lack of hygiene, poor care practices, child disease, and poor biodiversity. A lot of open defecation, so only 15% of the households had actually access to a pit latrine. Action Against Hunger did a multi-sectoral program for 3 years to improve nutritional resilience, and we targeted 22 villages, which corresponded to a little over 3,000 households. So our wash component consisted of both hard and soft components. We did construct new wells as well as rehabilitated old ones. We did a lot of hygiene promotion. I'll talk about that in a second. And we did social marketing of 3 products. The first was rainwater jars, big clay jars. The second was ceramic water filters. And the third, which is the focus of this verbal, were pit latrines. So we designed 2 types of models. There was one basic model that went for around $90 and an improved model that had a water basin, as you can see to the left. We targeted the households through a variety of mechanisms. So we had about 100 wash trainers, a lot of care groups and local leaders. And then we set up savings groups. We had 37 of those to try to get the poorer households as well to access these latrines. They would save $5 a month, and after a year and a half, everyone should have bought a latrine. So this was decided when a household would be able to buy a latrine was decided by lottery. So here's a little bit of an overview of the different mechanisms that we use. So we used the local village chiefs, dozens of care groups to promote a social marketing approach, about 100 of wash trainers who essentially did door-to-door visits. And then we worked with local business owners, so those were the ones who were constructing the latrines for the households. If you have project results, so we went from 15% of the households who had a latrine to 52% at the end. Our sanitation marketing approach, I need to specify this, lasted for a year and a half, really not much more than that. We reduced open defecation. We achieved one village that got open defecation free status. As a reminder, this was not done through CLTS, but purely through sanitation marketing. And we sold over 1,000 of those latrines. That represents around $137,000. Drinking water improved, and hygiene practices improved significantly. Yes.
Really quickly, your mic is breaking up a little bit. I'm going to ask if you could turn off your video, maybe to help with bandwidth.
So I turn off my presentation.
Oh, no. Just your personal video.
Yeah.
Okay, and you can go back into presentation mode.
Yeah, thanks.
Fantastic.
Second. All right, there we go. So our study objective, as I said, we constructed over 1,000 latrines through this approach, which represents around a third of all the households. But of course, we did not reach everyone, and we wanted to evaluate or to better understand why some households decided to construct a latrine and others didn't. So you see the variables here. I mean, was it because of the benefits they perceived differently? Did they perceive risks differently? Was it aspects of the marketing strategy that we used? Product attributes, equity, existing or changes in wash conditions and practices, social norms of peer pressure. And to do this, we designed a case control study. So how did we do this? We had a list of around of all the households who purchased the latrine, did some cleaning. Out of that list, we selected 10 villages using probability proportionate to size, and then selected 100 cases who purchased one of the two models. So then we matched those cases. We have the list. We matched them in the field with an equal number of controls who did not purchase a latrine and also didn't have a latrine at the time of the survey. We matched them based on the following criteria. They had to be from the same village. Of course, they had to be exposed to the intervention that we did, had to live there for a number of months. Household composition had to be very similar in terms of, for instance, number of children, and the respondent needed to be involved in decision-making around purchases of assets. Then we administered our survey and analyzed it using standard statistics. What were the results? Well, first of all, something we were a bit afraid of, but the matching worked actually really, really well. So we started out the survey with, for the controls, we started it out with a couple of screening questions, and this worked fine. Out of our cases, an absolute majority purchased the improved model, Model B. And out of our controls, as you can see, 90% practiced open defecation. Which of the variables were associated or linked to purchase or not? So was it wash conditions and practices? Well, we saw an enormous change in wash knowledge and practice, but we didn't see a difference. The difference we saw, to specify, we saw a difference, but the difference we saw was associated with the latrine, not with anything else. It's a consequence of the social marketing approach. A bit of a sobering result. Was it thanks to our marketing strategy? Well, unfortunately, it wasn't really. We didn't see a difference at all in exposure to either the care groups or visits from the local businessmen. We saw a difference in participation in community awareness activities, but it was actually the controls, those who didn't purchase the latrine, that participated more. And in terms of our staff visits or attendance to a wash training, this was a minor motivator for people to purchase the latrine. Perceived benefits, very similar. We don't have any reason to assume that this played a role in the decision-making around the purchase. Similar for perceived risks of disease. So while we saw a difference for hand washing, we did not see differences for sanitation. Product attributes is a little bit more difficult to compare between cases and controls, of course, because I mean, controls haven't bought a latrine, but there's no reason to assume that that controls would think that the product is less attractive. Finally, for social norms and peer pressure, we did see differences. So our controls had more neighbors that were defecating in the open, and they were less likely to exert peer pressure to newly arriving households, for instance. Whereas our cases, a lot of them, most of them actually recommended the latrine to friends and family. And finally, the most significant variable was around equity and affordability. As you can see in the graph below, we had most of the latrine purchasers who were in the richest quintile, and this was significant. And among the two poorest quintiles, or most of our controls were located. Cases also had more savings, and for most of the non-purchasers, cost was the main barrier. And then finally, 6% only of our cases actually used a latrine savings group. So this was for us a little bit of a disappointing finding. A couple of limitations: we had a higher response rate among controls, a higher non-response rate among cases. Sorry, we couldn't match for household decision making. While we know that this is a variable that could have an effect, we use it for matching. And there might have been some confusion between the ACF interventions and other interventions from other organizations in that area. To conclude, we significantly or substantially improved sanitation coverage in our intervention area, but we reached the wealthiest households, and our savings groups suffered from a lack of trust. And then finally, I think this case control study was an interesting study designed to not only evaluate the effectiveness, but also inform future interventions. Thank you. And now I want to open this to any questions.
Thank you so much for that presentation. I would like to remind everyone that we can ask our chat questions in the actual chat box that Mary Margaret shared at the beginning of this presentation. That's found on the actual platform. So I don't know if you're able to see the chat, but I will read questions out just to make things easier. Melinda asks, what are some of your strategies based on lessons learned to target those in the lower wealth quintiles?
It's a good question, but it's unfortunately we currently have closed our offices in Cambodia, and I mean we're using these findings to do future assessments with the same methodology in other countries, but we're not gonna implement the sanitation marketing approach anymore in Cambodia. But what I can say is that it was the main mechanism that we used to reach the poorest was the savings groups, and this, I mean, according to our findings, unfortunately, didn't really work. Other people have suggested use of microfinance institutes, but this is something that we tried from the beginning and that we had to move away from because that didn't work either.
All right, we have a couple more questions. We had 3 more minutes for questions. So anyone who has any other questions, please also put them in the chat. Elizabeth asks, what kinds of survey questions were asked to assess joint decision-making in the household? How was bias addressed?
Yeah, so as I said, we didn't assess household decision-making as a variable, and this is a weakness in the study. It was a screening question that we used to match our controls. The reason for this was that if we would have respondents that would not be involved in decision-making around purchases in the first place, then this would really bias all of the other results and all of the other variables. So I'd say this is a weakness. And we basically, for the screening questions, we basically asked people whether, I mean, I need to check because we asked over 100 questions, but we basically asked people whether they would have a say or whether they felt they had a say in buying a latrine or something similar.
Thank you. One last question from Pete is, Why, what factored into the decision-making for dropping the sanitation marketing in Cambodia? Was there anything specific that led to that?
Is there a story? No, there's no story, Pete. It's we decided to close our office, as sometimes happens with international NGOs. So unfortunately, we can't replicate this. That's it. There's no story to it whatsoever.
Fantastic. I think that is all the time that we have for Bram today. So thank you for a great presentation and some good insights. At this point in time, our next speaker up is Ryan Sinclair from Loma University. Ryan, if you would be able to share your screen, I'll give you a confirmation. Yep, I can see. Let's see the screen.
Okay, can you see me and hear me?
Yes, you're coming through clear.
Okay, great, and you can see my screen, great. So, hi everyone, I'm Ryan Sinclair. I'm faculty here at the Loma University School of Public Health, and we're in Southern California. And I had the opportunity to work on this project funded by the Pew Charitable Trusts regarding sanitation and some of the issues with sanitation around California and some disadvantaged unincorporated communities. I worked on it with the Leadership Council for Justice and Accountability, as well as some of our own teams. So Phoebe and Rebecca are from there, and Thomas and Josi are from my team at Loma Linda. So just as a primer, I know this is kind of starting out a little bleak, but I wanted to give you all a picture of the worst case scenario for sanitation in California right now. So this is from Riverside County. This is something like a consolidated septic system. I don't know exactly what it would be called, but it's where a bunch of mobile homes are coming together and sharing a septic system, and it's overflowing and going in a little trench behind a bunch of people's houses. So it's open sewage. And this is not what we want for, prevention of disease. This is a really bad situation. So this is one of the communities that we approached with this project. So what we used was a health impact assessment, and that's a framework that's used by the Pew Charitable Trust. A health impact assessment is kind of like an environmental impact assessment. It looks at the impact to health, just like the impact to environment. But instead, in this case, we're looking at the impact of something that's either built up, like say a building or infrastructure or something that's neglected. In this case, it's neglected septic tanks, neglected septic systems. So what's the impact to health? And so we use that framework, and the goal of that was to try to impact the county of Fresno to include wastewater infrastructure for disadvantaged unincorporated communities. So just to build that up, it could be either decentralized systems or can be improved septic systems, something, just include it in the general plan. So the challenge for us was to use the HIA format to go and get our stakeholders involved, the governmental and the community, and then draft a report, and then hopefully motivate the stakeholders to move and then improve this. But the method that we used was to, of course, bring in the stakeholders to give us some framework there, but then we infused it with QMRA and some GIS and epidemiology. I mean, it's a lot. I'll try to present what I can in this one, but I want to emphasize the policy process here and the stakeholders. This is the HIA. This is 6 steps: screening, scoping, assessment, and then monitoring and evaluation. In general, the QMRA and the epidemiology and the GIS are kind of in the assessment format here, while the getting everybody involved and reviewing the policies is kind of the screening and scoping steps. So in this presentation, I'm gonna go through these 6 steps. So the first one was your screening and scoping. And so we built up a community advisory group in the different communities, and we're focusing on Fresno here. That was the biggest one that we did. And then we followed the typical like community-based participatory research process, but it's actually the HIA process. And it's beyond engagement. We wanted people to be involved, not only to identify problems, but also throughout the research plan and into policy. and we gave them an opportunity to steer the data collection process as well. So we have pretty frequent meetings with the community, and that's important for the HIA. And so the screening and scoping, it kind of builds in some frameworks here. California passed a law called the Senate Bill 244. And that requires local governments to do a couple of things. Two of those things were map disadvantaged unincorporated communities, and also to describe their wastewater and water needs. And throughout California, that's rarely done. Local governments in California, there's rarely any governments that have done this. And so in Fresno County, we found an incomplete analysis. There's uneven census data. There's oftentimes the disadvantaged communities will share a census tract with an affluent area, so you get really kind of a skewed picture that way. And then also there's the general plan that's already there, kind of has a conditional language built up in it. So the result is right now there's no real data for Fresno County about access to wastewater service. So in part of our screening and scoping, we looked at the general plan and some of the language in there. We found a lot of conditional language, that is language that could be modified based on convenience. So things like shall encourage, or if a septic system represents a potential threat to groundwater, notably not public health, but to groundwater. And then the county shall limit the expansion, wastewater treatment facilities can be provided. So there's a lot of conditional language in there. And so that was one kind of target for our partner leadership council to improve the general plan under a Senate bill. And so we went and started our assessment, and that's where we built in our QMRA, which is quantitative microbial risk assessment, GIS, and epidemiology. But we found some things from our advisory group in the community, and people were telling us about these things. They were concerned about increased illness, stress and anxiety, exposure to pathogens from the soil, and then some other things. And so we were able to take that and sort of move it into a QMRA, and they helped us come out and do some soil sampling. And so we did soil sampling in a variety of communities, and for our QMRA, that informed our concentration estimate of different pathogens. And then we did the exposure assessments to kind of look into children's risk of getting sick, because we found that we needed to target a group that would actually have close contact with the sewage, which is children. And then did some more on the typical risk assessment process, and then infuse that into the assessment bit of the HIA. So, our concentrations over here on the right of Listeria, Salmonella, and Campylobacter, we're in a range typical of raw wastewater, and these are the concentrations in the soil per gram of these different bacteria. And so what we saw was that when we sampled the soil right above the septic systems in some places that had inadequate failing septic systems, you saw this these concentrations in soil. And this is another representation, but you do have Listeria, Salmonella, and Campylobacter there. And so we were kind of, at first, when I started doing this, it was alarming, but now we know to kind of expect it in some of these failing septic systems. And so this is our QMRA exposure model using surface area of the hand, contact time, transfer frequency. And so we built all of this up to estimate a child's exposure. We also had the dose response model on the bottom here, and the exposure model here. And I have all of this in a PDF in the report, so we can look at that a little bit later if you want. It's on the last slide, and so you can download the presentation and see that. So overall, our risk assessment, showed that most of the sensitivity that was controlling the bacterial concentration, or controlling the risk of getting sick, was the bacteria concentration in the soil. And then our risk of getting sick was really high for Listeria, Campylobacter, and then not as high for Salmonella. So we went to the epidemiology, county epidemiology, and we were able to download reportable diseases for the whole county. And we're able to look to see that Listeria, although our risk produced that, we should have like 15.1% of all people getting sick from it, we only had 8 over 5 years. And so that was an issue there. We're working on that and writing up some possible reasons for that. Could be something about listeria and virulence factors and things. But then we also looked at Campylobacter, and so we focused in on Campylobacter because that was the one that had the most out of all these sort of foodborne wastewater, potential wastewater-borne illnesses that you get from being exposed to soil. So that one had a high risk as well, and we focused in on that. We also did some mapping. Go ahead.
1 minute.
1 minute. Okay. So we did some mapping as well, and in the end, we finished our draft, and we circulated it to the county public health in April 2019, and the draft, and they really dug into some of our risk assessment and gave us some good feedback on that. And then that was it. And then many months later, February 2020, not that much longer, but we noticed that the county started producing some more data about wastewater and drinking water. And they started acknowledging the SB 244. And like most of public health and most water quality, I really feel like, some of these outputs when you're trying to impact policy at the governmental level, they're not going to call you up and say, hey, we read your report and we're doing this and doing that. They're definitely not going to do that, but they are impacted by these things. I believe that it's from this and also from some advocacy by local partners and the Leadership Council that they did start producing that data, which is pretty rare for any of the counties in California. Also, we have to continue monitoring them and continue with looking for change in this. There's also the Senate Bill 1000, which looks at the environmental justice element. Anyway, so that's what I have for now. And you can contact me at my email here, or I put Phoebe on here. She's one of the lawyers at the Leadership Council as well. And if you want to download the report, this is the PDF for it. Okay, so I guess I can take any questions now.
Thank you so much, Ryan. That was a great presentation. If anyone wants to post their questions into the chat, as we did before, that'd be great. Not a question, but a comment from Rochelle is that there is no plan for Fresno County is an important finding itself, unless the unit of intervention for the legislation is not the county, but still the data problems you identified are illustrative of a larger issue for unincorporated communities.
Yeah, it's pretty common for a lot of the unincorporated communities around California and probably the U.S. To not have anything written up addressing wastewater access, improved wastewater. It's also an aging infrastructure topic as well. A lot of these septic systems were built up in an era where they didn't do the proper testing at the county level to install them properly. And then in the last 20 years, they've been impacted by population as well. So they're underbuilt for where they are. And a lot of them are failing. So, there really needs to be a lot more effort put into sanitation in California. Now, we had this side session this morning where we discussed this a little bit. Any other questions?
So one question that I've received is, how is a disadvantaged community different from a disadvantaged unincorporated community?
Yeah, it's the disadvantaged unincorporated community is there to differentiate kind of this rural community from a disadvantaged community that you typically can also have in an urban area. So in Fresno County, which is, by the way, on this report, is this like right in the middle of Central California. Disadvantaged unincorporated communities are these like places that are also rural. You can have in downtown LA or San Francisco a disadvantaged community. So there's just two different terminology, two different terms that we can use.
Thank you for that answer. We have a couple seconds more if anyone wants to post a question in the chat. I will hang on for about 15 seconds for anyone to throw something in there. All right, well, thank you, Ryan, so much for that great presentation. Good to learn more about communities that we don't always think of. At this point in time, we're moving on to our final speaker for today, Kanika Singh from WaterAid India. Kanika, if you could share your screen, that would be great. All right, we can see you and we can hear you. Oh.
Hello everyone, I'm Kanika from WaterAid India. Thanks to the Water Institute for this opportunity. So I'll be sharing the learnings from a study we did on sanitation safety in vulnerable and disaster prone geographies. We did this study last year. So to start with, let us first understand why this issue of sanitation safety is so important. So gaps, any sort of gaps in sanitation infrastructure can cause human contact with fecal matter, or it can lead to contamination of water, or in some cases, it can also affect the functionality and sustainability of the toilet infrastructure, which in turn, all of these can cause risks to the public health and environment. And in some cases, in case there are design gaps in the superstructures of the toilets, that can affect the user friendliness of these toilets, which may in turn affect the toilet usage. Now there are some very important factors which need to be considered for construction of toilet technology, which are related to the geographical terrains. So one of the so these include water tables, soil permeability, rock porosity, rock permeability, and slope. So for example, in a high water table area, if the toilets constructed are not suitable to that particular terrain, it can cause contamination of water through unlined substructures, and also water can enter the substructures, thereby affecting the functionality, and so on. There are different challenges which can come up in different kinds of terrains. So I'm not going into the terrain-wise challenges right now, but we have a slide in the end of the presentation which you can refer to later, or I can try to cover it if we have time towards the end. As many of you may be familiar with the Swachh Bharat mission or the Clean India mission, which was Indian government's national flagship rural sanitation program. And this was implemented on a huge scale, and more than 100 million toilets were constructed across rural India within a very short span of 5 years. So in this context, in the year 2019, WaterAid India conducted a study on toilet technologies across 6 different geographic terrains. And the objectives were to understand the different kinds of toilet technologies deployed across these terrains, and to understand the types and extent of gaps therein. And based on these, to give insights or recommendations for achieving sanitation safety. Now, the data collection for the study was done around June and July of 2019, and we covered 6 different terrains. You can see the list of the terrains on the right-hand side. So we conducted household surveys of close to 3,000 households, and also interviewed 12 masons. The data collection, apart from the survey, it also involved observation of the toilets and documentation of photographs of these toilets. And after we completed the data collection, we conducted a series of consultation with sanitation experts to come up with the recommendations. Now, based on the survey findings, we did an analysis of the different kinds of substructures prevalent across these terrains. So we, based on some parameters, we classified the substructures into two categories: suitable for terrain and not suitable for terrain. So a substructure which is suitable for terrain means that it does not lead to water contamination in any form, or and also it does not lead to human contact with fecal matter. So for example, in the coastal region, around 51% toilets were suitable to the terrain. In the flood-prone region, around 44% toilets were suitable, whereas 43% were not suitable, and so on. If we see in this graph, apart from the desert region and the black soil region, all the other terrains had some, we found concerns about the suitability of toilets in all the other terrains. And apart from this, there were some percentage of toilets for which we could not conclude whether these were suitable or not, because based on the survey data available, we were not able to conclude as to what kind of substructure technology was present there. So we could not identify these as suitable or not suitable. Apart from this, we also identified certain gaps in the substructure design. So, for example, the ones on the left, which include, 64% of substructure did not have a safe horizontal distance from the water source, and also around 29% substructures were not covered from the top fully. So these could lead to potential risks for health and environmental safety. And if we see the ones listed on the right, so these were the design gaps which could affect the functionality of the toilets. So for example, 56.7% substructures had more than the permissible depth. So they were, for some of the substructure, they were as deep as 10 meters also. And 40% fully lined tanks did not have a vent pipe, and so on. So these were the different types of design gaps, and this gives us an idea of what are the retrofitting or design correction needs in these areas. Another set of very interesting and useful findings was around the readiness for substructure correction amongst the community. So we saw that most of the toilet users we interviewed, they expressed a higher interest for superstructure related modifications, which included repair of door, roofs, walls, etc., as compared to the substructure related modifications, although the need for substructure related modifications was higher. And this meant that we may need a lot of convincing and a behavior change in the most, especially in the most vulnerable regions, to build acceptance among the community. And also, if we see for the masons, so we found that the readiness amongst masons was also low, because many of the substructures which had to be corrected were already in use, and many of them would require some sort of emptying beforehand. And in the Indian context, the work of cleaning of substructures or the desludging of substructures is restricted to some particular communities, and there is a lot of stigma and taboos attached to this kind of sanitation work. So in this case, we may also need to address the issue of social dynamics amongst the masons if we are to go with repair of the substructures. Now, coming to the learnings for ensuring sanitation safety in large-scale sanitation programs. So the most important learning here is that we need to reinforce the linkages of sanitation with public health as well as environmental health. So for that, we have classified the recommendations into three categories. The first is regarding promoting adoption of appropriate technologies in large-scale sanitation programs right from the very beginning. So for this, we would need to have some measures in place, such as building technical know-how amongst actors at various levels, capacity building of toilet users, and also adding indicators on sanitation safety in the monitoring systems. Apart from that, the second recommendation is around having measures in place for correction of toilet structures as required. So this would include technical training of engineers and masons and building acceptance at community level for correction of substructures, having FSM systems in place which also have measures for preventing human contact with fecal matter and ensuring safety of the persons involved in these operations, and having provisions and arrangements for funds for design corrections. Especially, we would need to have additional support for the most vulnerable and disaster prone regions. And lastly, we also recommend some areas where we need some more research and pilots to address the current knowledge gaps. These include design corrections in the disaster prone or vulnerable terrains, such as the flood prone areas or the coastal regions, etc. And the second is around building acceptance for alternative and less popular toilet technologies like EcoSan toilets and biodigester toilets amongst the users, so that these can be adopted sustainably in these regions. And the third is to pilot effective behavior change communication approaches for communities so that they may be ready to adopt the suitable technologies and also to go for design corrections wherever required. Um, so Thank you. And with this, I think we can close the presentation now. I hand over to Tim in case there are any questions or comments.
Thank you, Kanika. Great presentation.
Yeah, and sorry, you can contact us on these email IDs. So me and my team, Raman and Arundhati, who were the co-investigators in this research.
All right, thank you. So once again, if anyone has any questions, please direct them into the chat on the conference platform. One initial question that was posed was, how do you define the suitability of toilets for a particular terrain in the study that y'all carried out?
Okay, so for suitability of terrains, we considered two major factors. So one was around that a suitable toilet substructure will not lead to water contamination, and the other factor is that it will not lead to a human contact with fecal matter in any way. So based on these two parameters, we made this list of suitable substructure technologies for different terrains. So for example, in this table, sorry, we could not cover this in the main presentation, but so for flood prone region, the suitable substructure technologies would be any technologies which are fully lined. So these would include septic tanks, biotoilets, and ecosans. And any other technologies apart from these, we are categorizing as non-suitable because these can lead to water contamination through various forms, and water can also enter, the flood water can also enter the substructure, so that can affect the functionality. And likewise, for each of the different terrains, we identified the potential challenges and also listed the suitable substructure technologies.
Thank you. Another question is, do you think that, oh, sorry, just lost it. There we go. Okay, so what were the most frequently encountered issues and what caused them? Was it things like uninformed builders, specific reasons to ignore best practice, or other items?
Okay, so actually in this study, we could not look into detail into the issues which caused these design errors, but we had conducted another study just before this, and we were able to find out some reasons as to why there were gaps in the toilet structures. So one of the most important reason was that at the implementation level, both at the part of the toilet users and also at the part of the local functionaries who were mainly leading the toilet construction drives. So there was lack of information at the local level, due to which people did not know what is the a suitable technology for their area, and even if the substructure technology was identified correctly, some of the design specifications were not being followed. And we also, in our interviews with masons, we found out that uh, you know even the definition of septic tank varied from person to person, and each person was actually interpreting septic tank very differently, and they were therefore they were constructing it in different ways, which was which was not aligned with the design specifications. The other reason, which is also partly linked to this, was that most of the toilet construction, like from our studies, we have understood that it was quite top driven, and the involvement of the toilet users was actually not much, and therefore they could not also uh, be involved in various decision making related to which toilet technology should be adopted and how the toilet should be constructed. So there were some gaps in the kind of materials which were procured and the processes which were followed as well.
All right, that is all the time that we have for comment today. I would recommend for all of our attendees and our presenters to continue to look at the chat, maybe answer any unanswered questions if you are a presenter, or pose any questions that you still have as an attendee. That is the end of our session today. I would like to thank once again all of our speakers. One shout out that I didn't get to mention at the beginning of this session is that our first presenter, Bram Riems, actually was one of the winners of the top 10 abstracts. So congratulations again to you for that. Just to re-announce the different things, I apologize for clicking through, to re-announce, if you are looking for information about the conference, go to the announcements and the FAQ tab inside of the conference portal. You can also attend the poster session, which begins in about 10 minutes by going to agenda and then all posters, and then selecting which sessions you want to join. And then lastly, remember that there will be an exhibition hall open tomorrow afternoon from our sponsors. That is at 3 p.m. Eastern Daylight Time for American Eastern Time. So if you're in a different time zone, please factor that in. That is it for today. I will be ending the recording and wanted to say thank you again for everyone joining us. You'll have a great day.